Thanks to a bursary from the Association of Paediatric Chartered Physiotherapists, I was able to attend the World Congress of Sports Physiotherapists in Nyborg in Denmark in August this year. And there were some absolutely fantastic presentations, and I just wanted to share with you some of the findings from that so everybody can benefit from the learning. And one of the workshops was the overuse injuries in adolescents. And this complemented two other presentations by Ben Smith and by Mikael Rathleff. But this particular presentation was with Charlotte Anker-Petersen and Kasper Krommers. And what I want to sort of dwell on are these four key themes. Is in the new recent research around both patellofemoral, this is focusing more on Osgood Schlatters, in relationship to our rehabilitation. And the four questions I posed myself from these particular workshops were that not all swelling around the anterior tibial tubercle is Osgood Schlatters disease. We can't just jump in because it sort of looks like it is. We have to explore whether all the features fit. Do you tell your patients with Osgood Schlatters that they're going to grow out of it? How can we identify those patients with Osgood Schlatters that have the potential for longer lasting symptoms? And how can we implement really good support systems and education and exercise programs so that we can optimize the recovery in young patients with Osgood Schlatters? So one of the key messages was that just because it looks like Osgood Schlatters doesn't mean it is Osgood Schlatters. So there are other things that can cause swelling and prominences around that tibial tuberosity. And one of those that was presented was that of osteochondromas. And these are benign tumours. They most commonly occur in the long bones in that sort of metaphyseal area. And whilst mostly they're seen in the distal femur and in the humerus, they can occur in the tibia as well. So a case study was presented from a 11-year-old boy who presented with a swelling over that tibial tuberosity. But relevance was it wasn't tender. It was larger. And in fact, when they extracted this one, it was 5 centimetres by 4 centimetres by 2 centimetres. So it was a big prominence and it was getting bigger. And it wasn't made worse by activity, which we would particularly expect that a Osgood Schlatters patient would be tender on palpation, it would be activity dependent, and when they did in fact excise this, the histology was different as well. So I think we need to make sure that the features fit, and as well as benign tumours, because of this metabolically active tissue, you can't exclude getting more sinister tumours as well. There are also other conditions. You can get problems with the epiphysis, not just the apophysis. We can get stress fractures in that area. And there are many other sort of conditions around the knee that may mimic some of the symptoms we see in Osgood Schlatters. So keep your wits about you and make sure that the features fit. Do you tell your patients with Osgood Schlatters that they're going to grow out of it? Because in this study that Sinead Holden et al. Did, is that 51 adolescents aged between 10 and 14 were diagnosed with Osgood Schlatters. And what they did was did some baseline ultrasounds, and they classified each patient according to the type using the De Flavis classification and the maturation of the tibial tuberosity. They, in addition to that, looked at secondary outcome measures, and there were several studies within this group of adolescents, and lots of really good results have come out of it. But in this one, they were trying to look at who was most at risk of prolonged symptoms. And bear in mind, some of them in this study, as many as a third, had a mean duration of persistent pain lasting 42 months. And those that were associated with more chronic pain or longer lasting symptoms had lower baseline outcome scores at the outset. So maybe we could have predicted it. But also on ultrasound, they had a much higher De Flavis classification. And in fact, you can see in this image from the paper that those with an associated bursitis, particularly the prepatellar bursa, did have more pain at follow-up 2 years later. And 32% had thickening of the patellar tendon and this increase in Doppler activity with ununited ossicles in some or bursal involvement. So if we were to do ultrasounds at the beginning of presentation, we could probably predict those who may go on to have a more chronic presentation and therefore maybe look at different interventions. So if we just think about a further study done a few years earlier, and there has actually been another study done more recently which maybe slightly contradicted this study, but I think this is still worth looking at, because what in this situation was there were 20, so a small study, but 20 symptomatic adolescent male athletes, similar sort of age group, and these guys had either unilateral or bilateral Osgood-Schlatters, and they were assessed against an asymptomatic group of similar athletes within the same cohort, and those that didn't currently have any symptoms of Osgood-Schlatters. And what they did in this one was, again, they did the ultrasound and the Doppler to assess both maturation stage of the tibial tuberosity, but also to examine the local soft tissues. And they did VAS scores on palpation of the tibial tuberosity and on a resisted contraction of the extensor mechanism in 90 degrees flexion in the prone position. And they also did VAS scores for the single leg squat. Now, interestingly, when they were looking at it, that certain things jumped out. And what they found was that those that were in the second stage of maturation, so stage 2, had more positive findings on Doppler examination. And all of them had inflammation in the bursa. And they had higher VAS scores on palpation and higher VAS scores on resisted knee extension, but the single leg squat test didn't have those same findings. And what they also found was that there was more vascularization, more neovessels evident in stage 2 and 3 of the maturation, and in particular the stage 2. And what the authors looked at was that Doppler activity may identify this propagation of the neovessels. And that appears to be in other studies regulated by the vascular endothelial growth factor. And is it that this starts to become overproduced in response to these compressive forces that occur with the quads tendon and compressing the against the growth plate? And maybe that has been associated in other studies with this neovascularization causing a proliferation of nerve fibers, and that could be what then causes persistent pain. So there's lots of sort of things that came out of this study, which whilst it's older, I think was very valid in being brought into this particular presentation. So if we accept that they're going to have a longer duration of symptoms, and perhaps there's some insights into how we identify those most at risk, we need to change our clinical practice. And so these particular studies, again by the group from Aalborg University, in this instance led by Michael Rathler, then we can say, well, how do we support those patients better? And I will share with you some other findings from the Congress around the patellofemoral research, which was also very, very relevant and very, very helpful for working with kids with Osgood-Schlatters. But certain themes came up. That if we've got this neovascularization, it was suggested, therefore, that if we gave them 4 or 5 weeks, that might allow for some of these compressive forces and these inflammatory processes to calm down. And I don't think we currently necessarily intervene with rest. And it's got to be balanced, because not all of them will need to rest. What we've shown is that those perhaps who potentially have higher VAS scores on an isometric contraction, higher VAS scores on palpation, with or without an ultrasound finding, and perhaps they may be in the group that are a little bit less mature. And so therefore then we might say, well, the ones that aren't in that group could just carry on with activity modification. And what you'll see in the, if you download the educational supplements that came with these papers, you'll see that they use an activity ladder. So could we find a level of activity where they had an acceptable level of pain, but no greater than 2 out of 10 on a VAS score? And those that perhaps had more acute symptoms or lower outcome measures, maybe they could be given a longer rest period. What we then need to really do is create an environment for education, allowing these children to learn the self-competencies to self-manage, make their own decisions about how they want to implement the strategies we give them. But mostly really spend focus on both education, because what's been shown is that exercises alone are unlikely to bring about an optimal resolution. So I would encourage you to download these two handbooks. They're very, very useful both for patients and for our own knowledge. And they can be found in the appendices of both the activity modification for Osgood-Schlatters and a very similar one by the same authors for patellofemoral pain. And that education must address the beliefs of the patient, but also their parents. One of the things that was really highlighted in the different studies around patellofemoral pain was give them a name for their pain. Give them a credible explanation that they can use with their peers. And let's look at the factors that contribute to Osgood-Schlatters. What are the risk factors? And how can we share with them the ways in which they can modify their activities to reduce or mitigate those risks? What are the benefits of adhering to a treatment plan, and how will that look in a graduated return to sport programme? And really spending time looking at the different load variables, using that activity ladder, but making sure that you advise on how often, how hard, how frequently, what kind of activities that they may find are more successful in the initial phases, and then how to progress so that their cumulatively weekly load doesn't exceed the capacity of the tissues at that point. So lots of really good things, lots of great papers to go and read, and I hope you enjoyed this little tidbit of information I learned from World Congress this year. So I hope you've enjoyed that little snippet. If you want to learn more, then there is a more comprehensive blog with all the references in it. And also you can sign up to the MSK Peds Needs newsletter, which I cover research like this on a monthly basis, saving you time. Join up at angelajacksonphysio.com. And if you want to explore how you can become a Kids Back to Sport clinician, then please do contact me either by email on info@angelajacksonphysio.com or visit the website.